So the other day, a colleague of mine told me that her patient had a spa. I said, oh, your patient owns a beauty spa. She said, no. I said, oh, quick spa. No. Super spa? No. She has spondyloarthritis. Spa. Hello everybody, Dr. Ryan here. I hope you and your family are well. If you are enjoying my jokes and my videos, I strongly encourage you to hit that subscribe button, like and share my videos. Thank you so much. I truly appreciate it. I appreciate your friendship on my channel. God bless you. Today we're talking about spondyloarthropathies. Here's the outline of our talk. We're going to be discussing a clinical case. Then we're going to split spondyloarthropathy 8 ways in terms of an introduction, etiology, patient presentations, looking at signs and symptoms, looking at a plausible differential diagnosis, treatment and management, diagnostic evaluation, prognosis and complications, and that's it. And then, of course, we're going to encourage some scripture. Thank you so much, guys, for joining me. Fasten your seatbelts and put your helmets on. Let's get going. So Mr. Schober is a 25-year-old man seeing his primary care physician for evaluation of lower back pain. Oh, dear. Now, the pain is severe, worse in the morning, improved with exercise, and worse with rest. So it smells like inflammatory joint pain. In particular, nighttime sleeping is difficult. He does feel quite stiff in the morning for at least 30 minutes. An MRI of the lower back is obtained and shows active inflammation of our beloved sacroiliac joint. Oh dear. On further questioning, he reports a history of unilateral eye redness treated with corticosteroids about 2 years ago. A test for HLA-B27 is positive. Which of the following is first-line therapy for Mr. Schober? Is it A, infliximab, B, naproxen, which is a non-steroidal, C, prednisone, D, rituximab, or is it E, tramadol? No wonder. Guys, your spondyloarthropathies refers to a group of inflammatory arthropathies with a predilection for the sacroiliac joints and enthesis. Now, what pray tell is an enthesis? It is a point of insertion of a tendon onto the skeletal bone. That's an enthesis, all right? Now, spondyloarthropathies include, just remember the mnemonic pair. P is psoriatic arthritis, E is enteropathic, otherwise called IBD or inflammatory bowel disease associated arthritis. A is for ankylosing spondylitis, and R is for Reiter's syndrome. The other term for Reiter's syndrome is post-infectious reactive arthritis. All of these brothers share a common genetic haplotype with HLA-B27. HLA-B27 is your genetic buzzword, guys. Extra-articular features are common and include disorders of the skin, the infamous keratoderma blendobrachicum, nails, eyes in the way of iritis, mucosa, and the aortic root, in which we have aortic regurgitation, albeit not that common. Guys, let's look at etiology, epidemiology, and risk factors. So these disorders, as you know, share a common genetic susceptibility in that about 90% of patients affected with ANK-SPOND carry the HLA-B27 genetic haplotype. In cases of reactive arthritis, 50 to 75% of patients carry HLA-B27. In cases of psoriatic and enteropathic arthritis, HLA-B27 positivity is increased whenever you have sacroiliac disease. Now, there's a kind of preponderance amongst the Caucasians, with 7% of the Caucasian population carrying the HLA-B27 genotype. In patients who exhibit the HLA-B27 haplotype, the risk of disease is 10% with a negative family history and 20% with a positive family history. There are more than 11 allelic subtypes of HLA-B27, interestingly enough. Infections are thought to be a common trigger. In Reiter's syndrome, we blame gastrointestinal and genitourinary infections, which are common, including chlamydia, ureaplasma, Shigella, Campylobacter, and Clostridium difficile. Now, onset often occurs between the teenage years and middle adulthood. Males are commonly affected more so than females. Northern European populations, American Indians, and South American Indians have the highest prevalence, right? Okay, guys, how do patients present with SPA? They don't present in a shopping spree in quick spa now. No. They present with lower back pain, which is associated with at least 1 hour of morning stiffness and improvement with activity. There's limited motion of the spine and chest expansion, which you'll be able to tell when you're testing lumbar flexion. We'll talk about that test just now, the Schober test. Now, sacroiliitis, which refers to tender sacroiliac joints and large lower extremity joint arthritis, are pointers to disease activity. Enthesopathy refers to inflammation, swelling, tenderness, and or stiffness of the entheses. Classic examples: plantar fascia insertion, Achilles tendon insertion, tibial tubercle, costochondral joints, epicondyles, the ascus, which is the anterior superior iliac spine, and the trochanteric insertion, right? Now, in ankylosing spondylitis, we have ascending spinal stiffness with diminished chest expansion. In Reiter's syndrome, we speak about the classic triad of conjunctivitis, urethritis, and arthritis. Conjunctivitis, urethritis, and arthritis, 2 to 4 weeks after a preceding or an antecedent gastrointestinal or genitourinary infection. In enteropathic arthritis, the flare-ups of peripheral arthritis are associated with exacerbations of our cousin's Crohn's disease and ulcerative colitis. Okay, here's a beautiful box taken from Talley and O Connor showing us differential diagnosis for back pain, right? So remember that serious causes of back pain are rare in otherwise well patients. And whenever you see this infamous exclamation mark, it denotes symptoms for the possible diagnosis of an urgent or dangerous problem. So let's start with those. And what suggests malignant pain is that the pain is worse at rest, keeps the patient awake, is present for more than 4 weeks, including weight loss and known malignancy, right? That's obviously a problem, suggesting malignant pain. What suggests an abscess is that the pain is worse at rest, associated with fever and in a patient who is immunosuppressed or immunocompromised. What suggests Corda-Equina syndrome? Now, what is Corda-Equina syndrome? It is compression of the sacral nerve roots, usually due to a large midline herniation of a disc, but can be caused by infection or malignancy that causes spinal stenosis, narrowing of our beloved spinal canal, right? And this will present with severe pain, urinary retention or incontinence, fecal incontinence, saddle anesthesia, S345 around the anus, you know the stories, and leg weakness, okay? Remember that the sudden onset of tearing pain together with hypotension and shock will suggest abdominal aortic aneurysm, okay? Now, other somewhat less severe causes, what suggests ankylosing spondylitis is systemic symptoms and pain at rest. What suggests a non-specific or musculoskeletal cause will be a gradual grumbling onset with no neurology and recent minor injury. Okay, what suggests fracture of a vertebral body is sudden onset of severe pain in a patient who is known with osteoporosis, known risk factors for osteoporosis in, like, for instance, long-standing steroid use, trauma and tenderness over the vertebral body. What suggests sciatica? Now, sciatica refers to irritation or compression of your L4 to S1 nerve roots. Is that the pain radiates down the leg beyond the knee, and this suggests spinal canal stenosis with pain which worsens with walking and is improved by bending. Here we have a beautiful MedComic diagram. Thank you so much to Mr. Jorge Muniz and company over at medcomic.com. Here we're talking about ankylosing spondylitis, right? So we're making an announcement, B27, B27, wherefore art thou? So AnkSpond is a seronegative spondyloarthropathy characterized by back pain and spinal stiffness, right? Peripheral features includes uveitis, so you got a red eye, cardiac abnormalities, right? Cough, cough, pulmonary disease, right? As well as it's got a positive Schober test, we'll talk about that, and sacroiliitis, denoted by this dart heading into this guy's buttock, all right? Non-steroidals are first-line treatment. Don't forget the bamboo spine, which happens in long-standing disease, which you can appreciate on a plain radiograph. Alrighty, this is taken from Macleod's, guys. Here we're looking at the different distribution of joint involvement in polyarthritis. Now, polyarthritis refers to arthritis involving 5 or more joints, okay? So in picture A, we have the typical distribution of rheumatoid arthritis. It's symmetrical, involving the small and large joints, upper and lower limbs. Has a predilection for the C-spine and the knees, and the small joints, symmetrical small joint involvement of the hands, right? In picture B, we have the picture of psoriatic arthritis. The buzzwords here is that it's asymmetrical, affects the large joints more than the small joints, causing swelling of the whole digit, resembling a sausage like dactylitis, and you also have enthesitis. Remember, there's 5 clinical subtypes of psoriatic arthritis. We'll talk about that in a separate video, all right? And then we have axial spondyloarthritis. This is the topic for today, involving the spine and sacroiliac joints, with asymmetrical peripheral arthritis affecting the large more than the small joints and causing enthesitis. In picture D, we have osteoarthritis, which is symmetrical, affecting the small and large joints, affecting the carpometacarpal joint of the thumb, so it affects the base of the thumb, and the DIPs, right? Osteoarthritis does not like the PIPs, the proximal interphalangeal joints. Okay, guys, if you suspect spondyloarthritis, you want to encourage the patient to move their spine, right? So you want to test in picture A what looks like we're testing lumbar flexion, so ask the patient to bend forward and touch the toes. They should be able to do that. In picture B, ask the patient to extend the neck backwards and look up at the ceiling. In picture C, we're testing lateral bending, so ask the patient to slide their hands down the lateral side of the leg on the left and the right. And in D, we're looking at rotation, okay, left and right. Now, here we have the beloved Schober test. Now, what you do in the Schober test is you locate your anterior superior iliac spine, and then you're going to move that line medially until you have that point marked over the spine. Then you mark a point 10 centimeters above that, and then 5 centimeters below that. And you're going to ask the patient to bend forward maximally, right? And the distance between point B and point C should be at least above 20 centimeters. If it's less than 20 centimeters, that speaks to reduced lumbar flexion, which is a harbinger for a spondyloarthritic process. Okay, here we're asking a patient with ankylosing spondylitis to bend over and touch his toes. He can't even make it halfway. Look at this incredible distance between his fingers and his toes, guys. And what is unique about him is a so-called question mark posture. Alrighty, here we have a picture of iritis of the right eye. Here we have succinate balanitis. Alright. Remember, guys, the clinical features of all the spondyloarthropathies is the mnemonic BEADS, B-E-A-D-S. B speaks to back pain, E is enthesopathy or enthesitis, A is arthritis, D is dactylitis, S is spinal involvement. Once again, B for back pain, E is for enthesopathy, A for arthritis, D for dactylitis, S for spinal involvement, guys. Thank you so much. Okay, what's the differential diagnosis for back pain? We already alluded to this a bit, but it can be mechanical lower back pain, it can be osteoarthritis, it can be referred back pain coming from visceral disease, it could be DISH. What's DISH? Diffuse idiopathic skeletal hyperostosis, DISH. It could be sacroiliac septic arthritis, a psoas muscle abscess, especially in the patient who's immunocompromised. You're thinking about TB involving the psoas muscle, discitis or vertebral osteomyelitis in the way of Pott's disease, TB of the spine, which is basically a combination of osteomyelitis and arthritis, causing collapse of the anterior portion of the vertebral body and a gibbous formation, and that can cause paraparesis. Watch out. Okay. What's the differential diagnosis for inflammatory oligoarthritis? By definition, oligoarthritis refers to involvement of 4 or fewer than 4 joints, okay? Differential for inflammatory oligoarthritis includes JIA, juvenile idiopathic arthritis. It could be gout. It could be septic arthritis or gonococcal arthritis. It could be pseudogout, arthropathy of Whipple disease, Behçet disease, and other autoimmune arthropathies. It could be rheumatoid arthritis or everybody's favorite systemic lupus erythematosus, the WILF. Ow! Alrighty, guys, let's look at. If you suspect your patient has spondyloarthritis, how are you going to work them up? Nice to ask. So remember that the spondyloarthritis, they are primarily a clinical diagnosis based on careful history and physical examination. A positive family history of spondyloarthritis or psoriasis will obviously lend weight to the diagnosis. But you want to do x-rays of the sacroiliac joints. If possible, request what we call a Ferguson view, which is a view taken at 30 degrees cephalad angle, which will demonstrate sacroiliitis, but unfortunately, this may take up to 10 years to be diagnostic and to declare itself, right? But what you may see is bilateral sacroiliitis in Angst-Spond. You may see unilateral sacroiliitis in Reiter's syndrome, psoriatic arthritis, and enteropathic arthritis. Later on, you may see the so-called pathognomonic bamboo spine. We'll have a look at that film just now. MRI of the sacroiliac joints will demonstrate edema and joint effusion. Of course, HLA-B27 genetic testing is not diagnostic, but may lend weight if you suspect the diagnosis. May also be useful for genetic counseling. Laboratory changes generally non-specific. You have elevation in your erythrocyte sedimentation rate, your C-reactive protein. You will have anemia of chronic disease. You will have elevated levels of immunoglobulin A. In cases of Reiter's syndrome, culture for gastrointestinal or genitourinary organisms may occasionally be successful. Rheumatoid factor is negative, hence the term seronegative spondyloarthritis, because you are negative serologically for rheumatoid factor. Okay, here is the ASAS criteria, the ASAS criteria. Criteria for classification of axial spondyloarthritis. Remember, this is to be applied for patients with back pain for longer than 3 months duration who are young, below 45 years, right? So you can have sacroiliitis on imaging plus more than 1 peripheral feature, or you can have HLA-B27 genotyping with 2 or more spondyloarthritis features. So a sacroiliitis on imaging, we speak to active or acute inflammation on MRI, highly suggestive, smells like, looks like, quacks like a spa, and or definitive radiographic sacroiliitis according to the modified New York criteria. Or you can have HLA-B27 plus 2 other features. Now, other features of the spondyloarthritis includes inflammatory back pain, arthritis, enthesitis, especially of the heel, anterior uveitis, dactylitis, which is your sausage-shaped digits, psoriasis, Crohn's or ulcerative colitis, a good response to non-steroidals, a family history of a spondyloarthritis, HLA-B27 genotyping, or elevated CRP. So any 2 of those plus the genotype will make the diagnosis already. Here are just the cytokines involved in these particular peripheral features of spondyloarthritis. So tumor necrosis factor is everywhere, guys. It's responsible for enthesitis, uveitis, peripheral arthritis, psoriasis, axial arthritis, and inflammatory bowel disease. Therefore, TNF-alpha inhibitors are wonderful if you're looking at disease which is non-responsive to your non-steroidal anti-inflammatory drugs. Okay, guys, here we're looking at a couple of radiographs. So let's just get my pen in there. So in picture A, we have an AP pelvis radiograph in a patient who has non-radiographic axial spondyloarthritis, which shows insignificant sacroiliac joint changes. But the very same patient you do an MRI on, excuse me, in picture B, here the yellow arrow indicates cortical erosion of the right sacroiliac joint, and the white arrow indicates subchondral fat. In image C, we see an MRI of the same patient showing bone marrow edema, which is a different protocol on the MRI, which shows bone marrow edema on both sides of the sacroiliac joint. That speaks to sacroiliitis. Very subtle. Didn't declare on the X-ray, but declared in the MRI, guys. In D, we have an AP pelvis radiograph in a patient with ankylosing spondylitis. The blue arrows here indicate bilateral radiographic sacroiliitis. See how this patient in this particular film, we can see sclerosis, partial fusion, and erosions, right? All speak to sacroiliitis. There is severe bilateral hip disease with autofusion on the left, indicated by the yellow arrow, and diffuse osteoporosis, right? In E, we can see lateral lumbar spine film in a patient with angspon, and the blue arrow shows shiny corners, something we call the Romanus lesion, R-O-M-A-N-U-S, Romanus lesion. In F, we see an AP lumbar spine radiograph in a patient with angspon, and here we can see bridging syndesmophytes, beautiful syndesmophytes. And in this last picture, picture G, it's a lateral C-spine film where we can see complete ankylosis of the facet joints. Aha! It looks like a bamboo, hence the term bamboo spine, because you got bridging syndesmophytes throughout. Beautiful radiograph. Okay, guys, how do you manage spondyloarthritis? Well, there is no cure, unfortunately. Exercise, appropriate rest, and proper sleep position to avoid neck flexion can improve symptoms. First line, guys, non-steroidal anti-inflammatory drugs, or you can use intra-articular steroids for pain control and suppression of inflammation. Indomethacin usually more effective than other non-steroidals, but you want to rule out peptic ulcer disease and renal impairment because you know those deals right there. Non-steroidals can cause gastritis and can worsen peptic ulcer, and non-steroidals cause fluid retention, worsening CKD, and they diminish your production of your prostaglandins, and that's going to induce afferent arteriolar vasoconstriction and drop your glomerular filtration rate. Not good. Doxycycline for 3 months may be helpful in cases of reactive arthritis or Reiter's syndrome, may also be beneficial in other spondyloarthropathies. Sulfasalazine has a disease-modifying role in enteropathic, psoriatic, and reactive arthritis, not with angspont, guys. You want to monitor for sulfur toxicity and for cytopenias as a complication. Methotrexate is particularly helpful for peripheral joint disease, not for spinal disease. Liver toxicity is a major concern with methotrexate. You want to monitor your liver function every 1 to 2 months. Anti-TNF drugs, infliximab, certolizumab pegol, adalimumab, golimumab, etanercept may be useful for cases of angspon, psoriatic arthritis, and IBD. These agents appear to have a large impact in patients with severe spondylitis. Hip replacement or surgical correction of deformities may be necessary. Eye exam at least annually to look for uveitis. Consider echo if you pick up a murmur which is suggestive of aortic regurgitation on account of aortic root dilation. Okay, here's an algorithmic approach to working up lower back pain. This is taken from Harrison's beautiful diagram. So if your patient complains of lower back pain for more than 3 months, you want to do an X-ray of your sacroiliac joints, a pelvic film. If you've got definite radiographic sacroiliitis, great. It's most likely angspon. But if this is absent and you have the presence of other spondyloarthritis features, those being age of onset less than 45 years, inflammatory back pain, heel pain speaking to enthesitis, dactylitis, uveitis, positive family history for axial spondyloarthritis, inflammatory bowel disease, alternating buttock pain, psoriasis, asymmetrical arthritis, positive response to non-steroidals, and elevation in inflammatory markers, then you want to consider if there's 0 to 1 spondyloarthritis features, you do your HLA-B27 genotyping. If it's negative, fantastic, it's unlikely to be as angspon, but if it's positive, progress through to MRI. If you have 2 to 3 spondyloarthritis features, the same procedure, HLA-B27 genotyping. If it's negative, go through to MRI. If it's positive and you got a compelling clinical picture, most likely it's an axial spondyloarthritis. If you got more than 4 spondyloarthritis features with a compelling clinical picture, this is most likely an axial SPA. If negative, you go through to HLA-B27 genotyping. If that's positive, fantastic, it's an axial SPA. If it's negative, MRI. If MRI is negative, consider another diagnosis. If it's positive, axial spondyloarthritis. Okay, guys, we're winding down now. Prognosis and complications. In general, the prognoses of all spondyloarthricities are good given the fact that they receive proper physical therapy, proper medication, and exercise. There's a very highly variable prognosis. Spontaneous remissions and exacerbations occur, particularly in the early stages of disease. Morbidity is related to fused joints in the spine. Complications are many, including severe hip arthritis, which may require hip replacement, spinal fractures, uveitis, aortitis, osteoporosis of the spine, secondary amyloidosis, active pulmonic fibrosis, and complications secondary to chronic non-steroidal use. Anti-TNF drugs have significantly improved the prognosis in cases of ankylosing spondylitis, and enteropathic spondylitis patients are at risk for colon cancer. Watch out! Okay, so coming back to our clinical case, Mr. Shoba was a young male you saw with a complaint of lower back pain, typically inflammatory in nature, right? It's worse in the morning, gets better as the day progresses. MRI of the lower back shows inflammation of the sacroiliac joint. Further questioning, he says he had unilateral eye redness about 2 years ago, treated with corticosteroids. That could have been uveitis. He is HLA-B27 positive, guys. Which of the following is first-line treatment for this? It looks like, smells like ankylosing spondylitis. First-line treatment is your non-steroidal anti-inflammatories. Naproxen is a nice one. So non-steroidals are the first-line therapy for ANK-SPON, for which this patient has a classic presentation. All right, everybody, I hope that you will just allow me to encourage you from the Bible. The book of Proverbs, chapter 18, verse 21 says, "Death and life are in the power of the tongue, and they that love it shall eat the fruit thereof." Indeed, our words have power. Your words can encourage someone and build them up, or your words can break someone down and cause them to become depressed. All right, the book of James tells us that consider how an entire forest is set alight by a small spark. That is the danger there is in the inappropriate use of our tongues. And I pray that we will use wisdom before we speak. Always say something nice to somebody. All right, here are my references, guys. If you enjoyed this video, I strongly encourage you to subscribe to my channels and to like and share this video. Thank you so much. You can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on Instagram and on TikTok as well. We've got some exciting videos coming up. Rheumatoid arthritis, systemic lupus erythematosus, the wolf, and approach to anemia. Looking forward to catching you on those, guys. Have yourself a wonderful day, and I'll see you soon.